everybody. So we resume our ECG scenarios with this short history. This is a 50 years old male who is a heavy smoker. He presented to the ER with chest pain. Chest pain, as you all know, it will be like retrosternal. Sometimes it is like a fist-like, or the patient is holding all his hand all over his chest. This is called Levine sign, as per the American cardiologist Samuel Levine. Some years ago, he noticed that patients who comes with MI to the ER, they will be holding the hand on the chest, or sometimes they clench a fist all over the chest, and it is not like a breaking type of pain. It could be a widespread area of the chest, anterior chest. It can start from the epigastric region until the jaw. So this gentleman presented with chest pain. He is a heavy smoker, and this is a real scenario. And I will take you to what actually has happened after that. So any suggestion from the group? So anyone would like to comment? So chat is open. So please. Any suggestion? What is going on for this gentleman with chest pain? And he is a heavy smoker. So I would like people to comment. So if nobody would like to comment, I could comment. So this gentleman, as you can see, he came with ST elevation from V1 to V2 to V3 to V4 to V5 and to V6. There is also ST elevation in lead 1 and in lead 2 and probably also AVL. There is also Q waves. This is Q waves. So there is some starting to have Q waves. So this patient probably presented within 6 hours of chest pain. Looks he is in sinus tachycardia. It is regular tachycardia. And there is right bundle branch block. So there is the V1 is positive in V1, in V2, and in V3. So this patient presented with an extensive anterior STEMI, and he is a right bundle branch block in sinus tachycardia. The patient obviously had an extensive MI. So initially in the ER, we would put him onto a monitor because this type of patients can easily develop ventricular fibrillation or ventricular tachycardia. So monitor, attachment to a monitor is crucial. And we need to put 2 IV line, 1 IV line for medications, the other IV line to extract blood for troponin I, BMB, and other cardiac biomarkers. And then the patient will be given aspirin, clopidogrel 8 tablets, heparin 4,000, and then he will be pushed to the cath lab. So this is what has happened for this particular patient, but unfortunately, he ended up with a very poor LV function. This is also another ECG of the same particular gentleman. There is RBP with ST elevation from V1 until V6 and also involving lead 1 and AVL. The patient here is less tachycardic than the prior ECG. So this particular patient had an extensive anterior STEMI. He is a right bundle branch block. He has got sinus tachy, and we could observe Q waves. So since that time, this gentleman has a very poor LV function following his LV, his ischemic cardiomyopathy. So what do you think will happen to this particular patient of 2025? So after 20 or 18 years from his event of the anterior MI, ejection fraction is less than 25%. What could be the final management of this patient? So this patient in particular ended up with an AICD because his LV function 3 months after the MI did not improve. And this is an AICD because we observe there is a sick lead here and there is a sick lead here. He also had to have a terminal LVAD because this is an LVAD. We call it left ventricular assist device, some kind of artificial heart. So this patient ended up with end-stage ischemic cardiomyopathy, but in order to keep him alive, we put an LVAD, and now he's doing well, by the way. So advances in medicine is quite unique now. I mean, we depend on technology like artificial heart and cardiac devices to keep patients alive. So we take another example of a 50-year-old gentleman who has so somebody said he cannot see the RBP, so I can just go back. So this is the RBP. So this patient, this is the RBP. When you have a wide QRS and a tall R in V1 and V2, and the configuration of the ECG is upside down, or we call that a rabbit ear. So this is like a right bundle branch block. So this is a right bundle branch block. So this patient had, as we said, he ended up with ischemic cardiomyopathy. He had to have an ICD and a terminal LVAD. Let us take another example of a 50-year-old gentleman who came in with chest pain. So I would like from the audience, please, to comment on the ECG, also to comment on the rhythm, and to say anything that could be of importance for this particular patient. So somebody was asking about the previous patient, whether it is an anterolateral or extensive, and it is an extensive anterolateral. So let us take this example of this particular patient who comes in with chest pain. Let me start. So this is an ST elevation in V1. You can see this is an ST elevation in V1. This is an ST elevation in V2. This is an ST elevation in V3. This is an ST elevation in V4. This is an ST elevation in V5. And this is an ST elevation in V6. So this is all the precordial leads are involved with ST elevation. There is reciprocal or there is inferior ST depression in lead 2, sorry, in lead 3 and AVF, and to some extent lead 2. The patient is in normal sinus rhythm. So the patient had an extensive anterior STEMI. He's 50 years old, and he ended up also again with severe ischemic cardiomyopathy, and eventually he received an AICD. So let us take the other example. So X-ray. So the X-ray show that this is an AICD because there is a sick lead here, and this is an old generation AICD. His chest is clear and the costophrenic angle is acute. So the patient is well compensated. Maybe there is a redundancy of the breast. I'm not sure whether he's taking spironolactone or other medications that can cause some gynecomastia. So this is a patient also again with anterior STEMI, and eventually he ended up with ischemic cardiomyopathy, ejection fraction less than 35%, and he received an AICD. So let us take this X-ray and the ECG will come after it. So what is your first comment on the X-ray? Anybody would like to comment on the X-ray?
So, thank you, Prof. When I look at the X-ray of this patient, specifically on the cardiac shadow, it shows like there is a dextrocardia because the apex looks to be...
Excellent. So there is dextrocardia. She's a female patient, by the way. So this is a female patient, and you correctly diagnosed dextrocardia. And the left side sign is here. So I am sure that this is the right side. Sometimes you need to check. So what is this? What is this going on in the chest X-ray? What do you call that? What type of cardiac device this patient is having? Anybody would like to comment? So this is dextrocardia, not an AICD. I mean, I could understand it could be an AICD if there is a sick lead on the wire. So if there is a sick lead on the wire here, and a sick lead again here, that could be an AICD. And this is a simple pacemaker, maybe an old generation pacemaker. So this is really a pacemaker which has a dual lead. So one chamber will be right atrium, the other chamber will be right ventricle. And importantly, what is this? So I would like somebody to comment on this circle. What is this?
So I think that is the bubble of the gas in the stomach.
Excellent. So that is the bubble of the gastric fundus. Excellent. Excellent. Thank you. Thank you, sir. Thank you. So that is well done here. What would you see on an ECG of a patient with dextrocardia before we open the ECG? And by the way, dextrocardia is very rare. It can occur 1 in 15,000. So dextrocardia has an incidence of 1 in 15,000. Sometimes it is associated with situs inversus, or sometimes it is also associated with Carter-Genner's syndrome and other syndrome. But it has an incidence of 1 in 15,000 individuals, and it is associated with situs inversus if it is complete dextrocardia or so. So what would you see on the ECG? Let us open the ECG. So the ECG, important to note that always lead 1 is negative. So in dextrocardia, lead 1 is always negative, and AVR, which is particularly negative in all normal ECG, is positive. So AVR is positive, and lead 1 is negative. So it is important to note that. The other important differentiation is the poor R wave progression. This is the R wave in V1. This is the R in V2 getting smaller, and this is the R in V3. When we reach V6, the patient actually has a very small very small R wave. So there is poor R wave progression. And what about the rhythm? What do you think about the rhythm? Anybody would like to comment on the rhythm of the ECG? Or what's this ECG rhythm look to you?
The rhythm on the ECG looks irregular.
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 Irregularly irregular. I agree with you. Looks like it's a sawtooth pattern, to be honest with you. And the RR intervals are not really, I mean, this RR interval is not like this one, or not like this one. So different RR spaces. So this patient had atrial flutter, and she has also a dual lead pacemaker, and she has the dextrocardia. So the dextrocardia is rare, 1 in 15,000. It could be associated with situs inversus, cartilage syndrome, bronchiectasis, and other issues. So let us move on. Thank you for your help and participation. So we move on to another scenario. Let us take this scenario. So 25 years old male. He came with chest pain when he takes breath in and out, but when he leans forward, he will feel better. When he goes back or lie down, he feels chest pain. So, I mean, I gave you an exact scenario of a patient who is having an atypical or non-ischemic cardiac chest pain, and he has pericarditis. So let us analyze the ECG. So in pericarditis, sinus tachycardia is common. So we have ST elevation, concavity upwards here, and here, and here, and here, and here, and to some extent in lead 1 and in AVL. So this is diffuse ST segment elevation, which is out of proportion to the degree of chest pain. Important to note, an important sign, we now are concentrating two important signs. The first one is called Budic sign. So if you make a line like this one, this is called Budic sign. I mean here, this is called Budic sign. So let us call it Budic sign. And the other one is called the PR segment elevation in AVR is called knuckle sign. So this is called knuckle sign. Some people believe the PR segment elevation in AVR is very diagnostic of pericarditis. But my advice to you, always consider STEMI, especially in young people. They could be drug abusers, they could be cocaine abuser. So if you are suspecting ST elevation MI, don't hesitate to take the patient to the cath lab. Cath lab is not going to harm the patient if the patient is having acute pericarditis or viral pericarditis, but you are going to harm the patient if he's a young patient and you missed an MI. And nowadays, the social habits of young people is getting different and is getting various degree of extreme. So you might get somebody who's 20 years and he's using recreational drug and other stuff. So it is important. Also, echo can show you small rim of pericardial effusion. Sometimes the echo might be entirely normal, but that does not rule out acute pericarditis. But if you are in doubt whether this is acute pericarditis or acute MI, please take this patient to the cath lab. So we move on to this interesting chest X-ray of a tall man, and he came with respiratory distress. So what is going on? What is the cause of his respiratory distress?
So,
Yes,
so when you look at his X-ray,
yes.
I will start with the airway. It looks to be central, but
Okay,
when you
central
look
X-ray. Yeah, yes, go ahead. All
when
right.
you look at the lung markings on the right, there
On
is
the right. So this is the right lung, has been compressed so much. So this is
yes,
the right lung, and this
yes,
is all air.
yeah,
So this is air. I would call it air. And this is the lung. So this patient is having, what do you call it? Tension
the pneumothorax.
pneumothorax. Yes, so this is tension pneumothorax. They say it is illegal to do a chest X-ray for tension pneumothorax because you should have diagnosed it before you send the patient to the X-ray, and important to do decompression needle. So decompression needle is important for tension pneumothorax. It used to be in the past in the second left interspace, but they say this can cause more damage. Now the accepted place is the fifth interspace. So no longer you do it here, you can do it here. So this is for the needle decompression of tension pneumothorax. So important. Young people, tall, who comes with acute chest syndrome, they can be having pneumothorax. So it is important to do a fast exam and a fast diagnosis. So let us move on to another 17 years old male. And this patient, I tell you, was the first patient I saw with pulmonary edema, was so sick that he was intubated in a short period of time. And he was producing very frothy sputum. So 17 years old, 23 years ago, as you can see here, came with a severe pulmonary edema. So what is going on with his ECG? If somebody would like to comment, please. Let us take maybe the rhythm. So we can see a B wave. We can see a B wave before each QRS, but the heart rate may be 100. So the patient may be borderline sinus tachycardia. And this is the patient who came with pulmonary edema. So commonly a patient with pulmonary edema will have a tachycardia or a tachypnea. So where is the abnormality on the ECG for this young man who is not known before to be cardiac? He had a very short illness of 1 or 2 days, and he came with pulmonary edema. And excuse me, I can point out he has ST elevation in AVL and has ST elevation in V2 and to some extent in V3. And he has ST elevation, maybe very shy in lead 1. So these are the leads involved with ST elevation. He has also ST depression in lead 2 and 3 and AVF. So if you have any suspicious ST elevation, the most important thing for a patient with pulmonary edema after intubation is to take him to the cath lab to make sure that he has no coronary obstruction. But it is odd that his ST elevation does not follow a regular pattern of coronary occlusion. So what could be the cause of such patient. Okay, South African flag sign, I could agree with that for sure. So, I mean, this is a good suggestion because in South African flag sign, there could be ST elevation in lead 1 and lead AVL and V2. Probably not V3, but I mean, this is very similar to the diagonal or to lateral infarction, which is famously known as South African flag sign. And there is also ST depression in lead 2 and 3. So I agree with you. It could be diagonal infarction, South African flag sign, and this is a very wise suggestion. So what other explanation for this gentleman ECG? Young age and pulmonary edema and a very short illness. No chest pain, but it is only shortness of breath. So the patient was taken to the cath. It was normal coronaries. And we diagnosed him as actually a case of myocarditis. Acute myocarditis, I mean, this is not acute myopericarditis. This is acute myocarditis can have very funny or bizarre ECG. So this is the one, and it could be also a diagonal infarction, but the patient did not have any diagonal occlusion. So this is a patient who has also acute myocarditis, but he came like an ST elevation scenario. So thank you. So this is a patient who had myocarditis. Remember, myocarditis or myopericarditis sometimes can have a very variable ECG presentation. So let us move on to another example. So this is a patient under endocrinology follow-up, and the endocrinology gave me a call, and he told me I did an ECG for this patient, and the ECG is entirely abnormal. Please evaluate her in the cardiology clinic. So would like from you, please, to comment on the ECG for this particular patient who had an abnormal ECG, and she's referred from endocrinology. I think she had some kind of thyroid disease. So what is obvious on the ECG?
So there is bradycardia and it is a low voltage ECG.
Excellent. Superb. Awesome. So there is bradycardia. I mean, especially the limb leads are quite low voltage. And the heart rate is quite brady, maybe like 40 or 40 something. Although it is regular, but sinus brady. There is also some T wave inversion, also prolongation of the QT, and maybe this is a U wave. So this is a typical example of overt, let us say, overt hypothyroidism. So this is hypothyroidism with sinus brady and with also low voltage ECG. So sorry, I didn't write it correctly. So this is so what we need is to actually do good replacement of thyroxine and to repeat the ECG and echo within 6 weeks to 6 months. So 6 weeks minimum to like ideally 6 months. So what are the cardiovascular problem with hypothyroidism? Hypothyroidism can cause hypertension, can cause cardiomyopathy. It can accelerate coronary artery disease, especially in the elderly people, and can cause heart failure, can cause bradycardia, and can cause precardial effusion. So all these are effect of hypothyroidism. So hypothyroidism can affect the heart in many, many ways. Can affect the myocardium itself, can affect the coronary arteries, can affect the pericardium, but it will not affect the valves. So it is important to recognize hypothyroidism and to treat by replacement therapy. So we move on to another example of an ECG scenario. So let us move on to this. This is a child ECG. Take your, children ECG are usually tachycardic. Don't think that this is atrial flutter, no, or this is like sinus tachycardia. But see the P waves. There is an abnormality of the P wave of this child ECG, or the P wave is obviously very abnormal. What is the height of the P wave? The P wave should be like 2 millimeters in height and could be 2 millimeters in diameter. So what is going on with the P wave? So let me show you what P wave I would like you to see. This is really a huge P wave. This is a child. We said always we need to look to lead 2. So the P wave is higher than the QRS. So the P wave is higher than the QRS, and it is like 5 millimeters. So what do you call this P wave in a child with congenital heart disease? So this is what we call a Himalayan P wave. A patient will have a very enlarged right atrium. This is called Himalayan P wave. It's called Himalayan P wave. This is the Himalayan mountain. And this is the huge right atrium of a patient with Bechstein. The tricuspid valve is migrated towards the apex of the heart. And usually, P wave will be like 5 millimeters in diameter in height in patients with Epstein anomaly. Sometimes it can occur with tricuspid stenosis or tricuspid atresia. So this is a huge P wave, right-sided atrial enlargement due to congenital heart disease of Epstein anomaly, which is a rare anomaly, but it can be associated with sometimes WBW syndrome, sometimes be associated with other congenital heart disease. So let us move on to another ECG of a patient in severe respiratory distress and engorged neck vein. So severe respiratory distress and engorged neck veins. So analyze the ECG for me.
So it is still low voltage. Then the heart rate looks to be tachycardic, but also there is as if alternation of the P waves. Some are the QRS complex, some are tall, some are short.
You are right, absolutely right. So the QRS, you are absolutely right. So the QRS here is small, the QRS here is big, the QRS here is small, here is big, here is small, here is big, here is small, but it is also extremely low voltage. The low voltage is actually involving both limb leads and precordial leads. So this is a massive precardial effusion with tamponade. And what do you call this phenomena? of abnormal QRS. We call it electrical because it is found. We call it electrical alternance. So it can be seen. It can be seen also in severe heart failure. So a patient with severe dilated cardiomyopathy, severe heart failure, you can see electrical alternance because the cardiac output, one beat will be small, the other beat will be little bit better. So it is really a marker of reduced cardiac output. So it is important to recognize such ECG because it can give you a hint that this patient could be sitting on a bump of pericardial tamponade, Beck triad. So you need to really treat him with precardiocentesis after you do under echo guidance, after you do your necessary workup. The X-ray will show what is called a water bottle chest X-ray appearance and water hammer appearance, and it is important to treat it. Thank you. So we move on to another abnormal ECG, young patient with occasional palpitation. So any suggestion on the ECG? So WBW, so let us see. Sorry, I came back. So this is WBW. This is what is called delta wave and a short PR interval. So delta wave, I mean, V5, V4 sometimes can be better than other leads. So WBW, let us remind you. So WBW occur like 1 in 500 to like 1 in 1,000. 50% of the cases have symptoms. 50% of the symptoms, 50% of the patients, they don't have symptoms. And they have abnormal bundle of Kent. This is a question for the USMLE. Okay. And the treatment of choice is ablation. You ablate the abnormal accessory pathway because otherwise the patient will be suffering a long time from palpitation. They can come with AFib or SVT, and they have increased incidence of sudden cardiac death. So WBW, it can be associated also with Epstein anomaly. It can be associated with hypertrophic cardiomyopathy. So WBW is important to recognize, and calcium channel blockers are contraindicated. Calcium channel blockers are contraindicated. So these are the facts that you should take into account when you are dealing with a patient with WBW, Wolff-Parkinson-White syndrome. It is a shortened PR interval. There is an accessory pathway between atria and ventricle in addition to the normal pathway. 50% of the patient will have symptoms. Other 50% will not have symptoms, but eventually they will develop symptoms. Anatomically, there will be a bundle of Kent. Ablation is the way you go forward in the treatment of those patients, because otherwise they need to be on lifelong medication like brocalamide or other class 1 antiarrhythmic. They can come with AFib and SVT, and they can come with wide complex tachycardia. They are associated with Epstein anomaly or hypertrophic cardiomyopathy. If you want to treat them in the ER, you treat them with procainamide. In the past, they used to be treated with amiodarone, but amiodarone sometimes could be useless because it will take more time and it could complicate the matter. So you prefer procainamide in the treatment of those patients with WBW syndrome if they come to the ER with rapid palpitation. So this is WBW syndrome. People used to divide them into two groups according to the V1 morphology. So if V1 is negative, this is called type B. If B1 morphology is positive, this is called type A. So you need to also, but the electrophysiology, they don't use this type of classification anymore. So let us take this X-ray appearance for a patient who comes to the ER with severe, he's an elderly gentleman, by the way. He came with severe respiratory distress. So let me see if there is any. So if you allow me, this is,
So,
yes, okay, okay.
so there are heterogeneous opacities more on the right, even on the left. But
Yes,
when you
right.
look on the left, this lung is a bit collapsed. There are no lung markings there.
You are right, yes, okay.
Okay. Yes.
So this is a collapsed lung here, and this is a COPD or a patient with pulmonary fibrosis, and he developed now pneumothorax. So the area which I am going to shade is going to be the air, abnormal air trapped. So this is called secondary pneumothorax. Primary, when there is no coexisting lung disease. So this is secondary pneumothorax. The patient needs to stay in hospital, and he should have an underwater drainage, because the patient will not have a reserve for his breathing or oxygenation. So those patients with secondary pneumothorax are quite sick patient, not like the primary in which there is no lung disease before. So let us move on to another example of a 37 years old lady who came with severe respiratory distress, and she was having positive troponin I, and she had increased thyroid markers. Let us take the other. TSH is very low. Let us go back. So the TSH is very low. So what is seen on her ECG? Let us give you the ECG. So what is the ECG showing? So the ECG is showing, sorry. So the ECG is showing sinus tachycardia, and I will show you why. So it is sinus tachycardia because if we take this, we can see the first spike is the T wave, the second spike is the B wave. So we have, it is sinus tachycardia with prolonged QT, but this is a patient who comes in with cytotoxic storm, and she's having a prolonged QT and sinus tachycardia. And those patients, usually cytotoxicosis patient or patients with hyperthyroidism, they can come with sinus tachycardia, or sometimes they can come with atrial fibrillation. So thyroid toxicity can produce either commonly tachycardia, simple tachycardia, or sometimes could be atrial fibrillation. And if they develop atrial fibrillation, they deserve an anticoagulation. So we need to look for those type of patients. Thank you. Let us take another scenario of a patient who has been sick in ICU 2 hours post-laparotomy for an ectopic pregnancy, and she is quite febrile. So let us see the ECG. This is her X-ray. I can just go through it. So this is an endotracheal tube. This is a central line in the right atrium. And this is a nasogastric tube all the way to the stomach. And these are the leads of the monitor. And the lungs are congested. So this is a patient, typical patient in ICU with congested lungs, intubated, mechanically ventilated, central line, nasogastric tube in, and she's young, she's 30 years old. She was referred to cardiology because of abnormal ECG and a raised central venous pressure. So what do you observe on the ECG? Any suggestion of the ECG? So the ECG is showing maybe the heart rate is 90, 95, but the voltage, I mean, if you look to the voltage here in the limb leads, it is like low voltage ECG. So first of all, it is low voltage. And secondly, there is like diffuse ST elevation, V5, V4, V5, and V6. Here, V6 particularly, there is an ST elevation and also lead 1. So again, this is a case of myopericarditis, can also present with ST elevation to the ER. So you need to take that into account. So this is a patient who came with acute myopericarditis. She has low voltage and diffuse ST elevation. This is her echo showing inflamed, thickened myocardium, and there is a small rim of pericardial effusion in a patient who has been pregnant for 2 months. So this is a patient with myopericarditis, and she recovered in a nice way. And she was given everything at that time to treat her myopericarditis. Myopericarditis, it's actually, the treatment is supportive. Sometimes we give steroids, sometimes we give immunoglobulins. And nowadays, ECMO should be used as long as it is in our hands and it is in safe hands. So ECMO should be used to mechanically support the heart and lung. And that is the same particular patient who had a low voltage ECG and ST elevation after 4 years from her acute decompensated myopericarditis while she was pregnant. So let us take another example of an ST elevation scenario. Where is the ST elevation on this ECG? And there is a phenomena noted on this ECG. There is a physiological phenomena noted on the ECG, and where are the ST elevation? That's MI here. Anybody would like to comment on the ST segment?
V1. It is V1.
V1,
V2.
excellent. So Sayer, you are right. So V1, there is an ST elevation significant. There is also ST elevation in V2, V3, V4, V5 to V6, not convincing, but maybe lead 1 and AVL. So this is like extensive anterior or anterolateral ST segment elevation. And what is the physiological phenomena? If you look to lead 2, the RR interval here looks a little bit narrower than the RR interval which comes after it. And this is called sinus arrhythmia. This is called sinus arrhythmia. And there is also ST depression ST depression LE3 and AVF. So this patient must be having an LAD occlusion, which is responsible for all these ECG changes. The sinus arrhythmia is a normal physiology. And in this particular patient, that was the LAD occluded from its proximity. And that is why V1 was involved with ST segment elevation. So this patient had an extensive anterior STEMI, and there was an ostial LAD occlusion, and that explained why the patient had an ST elevation from starting from V1 until V6. So let us take another example. This is almost a normal ECG, but I take you to another example of another ECG ST elevation scenario, and we can show you the ST elevation here for a patient who had an anterior STEMI, an inferior ST depression, which will make an MI likely. So again, this patient received an AICD. So maybe this will be maybe our last, but not least slide for a patient who came like 6 years ago with bad type of MI, but he recovered. So we'd like you to show us where is the ST elevation and what do you call this ST elevation shape? I mean, it looks like a box shape ST elevation. So any volunteer would like us? Tom Stone. So this is Tom Stone ECG. I mean, so this is what is called Tom Stone ECG, like the graveyard. So this is, I mean, here you can see that there is like a box ST elevation. This ST elevation is very serious, and it was involving from V1 until V6 was this patient was particularly involved. Even lead 1 and ABL, they were involved with the ST elevation. In addition to that, there was an ST depression in the inferior lead. So this is a patient who had an extensive anterior STEMI. Luckily, he arrested 30 times in my hand, but he made it. He made it well. And this was the cause of his 30 times arrest. This is small thrombus in the LAD, which was due to the smoking. We hope, let us, I think, take another example of another very, very interesting ECG. I think if you allow me, I will go fast to the last example. Okay, so what do you call the ST elevation here for this patient who came in cardiogenic shock? So what do you call the shape of the ST? Shark.
Shark fin pattern.
You are right, absolutely right. So it is called the shark fin ECG. And I found, by the way, TikTok clips of patients who are eating the shark fin itself. And the other name for it is called lambda sign, or it is also called giant R wave. So they say it is present in 1.5% of all anterior MI. It can occur with anterior STEMI or can occur with stress cardiomyopathy. Because the patient usually will be very, very sick, and he might go easily into arrhythmia or into cardiogenic shock. So by this, my colleagues, I come to conclusion for this scenarios of ST segment elevation, and I hope all the best for all of you. Thank you very much, and let us meet in the future at some other time. We can organize also another meeting about cardiology, ECG, or a chest X-ray. So thank you so much. When the recording is available, I will put it in your on the Twitter, and you can also take a look at it later on for your revision. And if you have any comment, you can comment on Twitter or personally to my box. Thank you very much. Thank you. Thank you.